Hi, so I'm going to tell you about the TMACS Choice Trial, which is a feasibility study looking at the value of shared decision making for patients with chest pain presenting to the emergency department in the context of suspected acute coronary syndrome. Now, we've already completed enrolment to the control arm of this study at Manchester Royal Infirmary and in Wigan at the Royal Albert Edward Infirmary. You might not have noticed if you've been working in those two departments that we've been enrolling these patients because the care has not changed at all. We've followed the patients up and we've gathered some really important data. Now it's time for us to move to the intervention period. And this is where we need the help of the clinicians working in the two departments because we're going to implement shared decision making. And I'm going to tell you all about that and what that means for your practice. So I'll tell you first a bit about the background to the study. Chest pain is a really important problem in the emergency department. 6% of all of our patients in the ED have chest pain. Approximately 1.3 million attendances at emergency departments occur because of a primary complaint of chest pain in England and Wales every year. Now, we suspect an acute coronary syndrome in about half of those patients, but only a minority of the patients where we suspect the diagnosis actually have a myocardial infarction. About 10, at best 15% of the patients where we suspect the diagnosis actually have it. And it used to be the most common reason for acute medical admission to the hospital. One of the problems that we've got is that the patient's symptoms are really poor at telling us whether they have a myocardial infarction. You can have absolutely typical symptoms for myocardial infarction, and yet it's a diagnosis as simple as indigestion. Or you can have really vague and apparently mild symptoms, just a little dull ache in the chest that went away after a few minutes, and it can be a myocardial infarction. This study by Ed Carlton and colleagues showed the sensitivity and specificity of typical chest pain symptoms versus atypical chest pain symptoms. And you can see the sensitivity is around about 50%, which is no better than throwing a coin. Specificity is not much better, and it didn't really matter if you're experienced or a novice. In fact, experienced physicians had a lower sensitivity than novice physicians. So the nature of a patient's symptoms aren't great at telling us whether they actually had a myocardial infarction or not. And neither is a patient's past history. The risk factor burden, we ask about hypertension, hyperlipidemia, diabetes, smoking, and a family history of premature ischemic heart disease. Well, the more risk factors that you have out of those 5, you might think the more likely it is that you have a myocardial infarction if you've presented with chest pain. It's not true. We've done 2 studies on this, 9 years apart, and you can see the number of risk factors that you have doesn't really bear much relation to the prevalence of myocardial infarction at all. Here are the ROC curves for that. Now, remember, the perfect ROC curve should go up to the top left corner where that 1.0 is. And that would have perfect sensitivity and specificity. A perfectly useless test will follow the diagonal. And that's what risk factor burden does. It pretty much follows a diagonal. It's useless at determining who has a myocardial infarction. And I could go on and on and on about the things that aren't predictive. So we need some help from diagnostic tests. We've got troponin. High sensitivity troponin has really revolutionized what we do, of course. We can work out whether it's a myocardial infarction within just an hour or 2 of the patient coming to the emergency department. And we've got decision aids. So I'm going to tell you about TMACS because that's what we use, and that's the basis for this trial, TMACS Choice. So TMACS was derived by logistic regression, a machine learning technique, combining elements of a patient's history, their ECG, and their first troponin result in the ED. Using that information, we calculate the probability of an acute coronary syndrome, and we stratify patients into 4 groups. We've shown in validation studies that this works much better than using a troponin test by itself. So the sensitivity for myocardial infarction is the same as just using a high sensitivity troponin assay alone at a really low threshold. So you can see that here. Sensitivity and negative predictive value, pretty much the same with TMACS and using troponin by itself. The difference is that TMACS is more efficient, has a higher specificity. So whereas just using troponin, we could allow 29% of patients to have myocardial infarction ruled out with one test, that goes up to 47% with TMACS. TMACS is also better than other risk scores. So here we've compared it to the heart score in a direct comparison. The heart score is very widely used, of course, but here in a direct comparison in a multi-center study, we showed that TMACS was superior. For one, in the middle of the horizontal bar chart, you can see TMACS allows you to send more patients home immediately. It rules out myocardial infarction in 47% of patients compared to 30% with the heart score. And it's got better sensitivity. Look at the rule out group. 0.2% of patients would have a missed MI with Tmax compared to 3% with the heart score. It risk stratifies across the board, and you can see in the high risk group, 80% of patients actually did have a myocardial infarction when they were identified as high risk using Tmax versus 37% with the heart score. So it won on every front. So this is how we use it in our practice. We calculate the Tmax probability, and then we stratify patients into 4 groups. We say they can either go home straight away with no more tests, they can go to cardiology at the other extreme, and we've ruled in the diagnosis. And then in the middle, we've got a low-risk group who can go to ambulatory care for their second troponin 1 to 3 hours later, and a moderate risk group that might need to go to acute medicine for further investigation because there's a higher ongoing risk for them. The vast majority of patients fall into one of the 3 other groups, so the ambulatory, home, or cardiology groups. Now, this probability that's calculated by Tmax is something that we own as clinicians. We know about it, but we don't tell our patients that probability. And you should therefore ask, well, should we? Because we're saying if your risk is less than 2%, then we could send you home and we achieve really good sensitivity and negative predictive value with that. But why should we set the threshold at 2%? Shouldn't a patient have the say in that threshold? Well, that's what Tmax choice is about. It's about saying that now with this machine learning model, we can calculate the probability of an acute coronary syndrome. How about we share that information with our patients and allow them to engage in the decision-making process? That's shared decision-making. Now, in the US, the chest pain choice trial run by Eric Hess showed that when patients were randomized to shared decision-making as opposed to standard care, they knew more about their care, they played a more active part in the decision-making process, as you'd expect, and they more often chose to go home without further investigation. What's more, there was no signal to them having a greater incidence of adverse cardiac events. So perhaps this is the way forward. Not only is it patient-centered and allows patients to have control over their healthcare and autonomy, but it also allows us to make more efficient use of our healthcare resources without compromising patient safety. So that's what this trial is about. Now, there are several models for using shared decision-making, but the important thing is you use one. Use a model to facilitate your shared decision-making. And in a Tmax choice trial, we're going to use one called the 3-talk model. So there are 3 easy stages to applying shared decision-making. Now, if you enroll patients into the Tmax choice trial, we'd like you to use shared decision-making when you've cared for a patient with possible acute coronary syndrome. So I'm going to tell you very, very simply how you can apply that in your practice. So use this 3-talk model, and there are 3 steps to it. The first is called the team talk. The second is the option talk, and the third is the decision talk. 3 simple phases. Let's go through what each one of those means. So in the team talk section, we're going to have got our test results back for this patient, the baseline troponin, we've done our baseline assessment, we've calculated the Tmax output, and now we've got a probability of an acute coronary syndrome. And we're going to introduce the concept that we'd like to share that with the patient and engage them in the decision-making process about their future care. So we'll say, let's work as a team to make a decision that suits you best. So we're introducing the concept that we're going to work together on making this decision. And that allows us then to sort of see how that lands with the patient, see how much of an active role they want to play in the decision-making process. Every patient is individual and different. Some will want to play a really active role in that decision-making process. Some maybe less so. They're happy to trust the clinician that's looking after them. And that's all fine. That you can use shared decision-making with varying levels of input. The point is we're giving them the opportunity to engage in shared decision-making. So you can still go through this process and you can tailor this process to that individual patient and give them as much choice as they would like to have. Having introduced this and agreed that we're going to work together as a team, we'll go through the options talk. So we're going to compare the possible options. Now, in the emergency department, we're really talking about whether, can the patient go straight home? Are they going to come in? Are they going to go to an ambulatory care area or a ward area? How are we going to treat them? Are there any alternatives to that? Could they go home and come back later for another test? Well, we're going to present those options to them. And we're going to present the relative merits of each approach based on our best understanding given the test results that we've got and the clinical context. And that's really important. So we can share with them there the probability, and I'll show you the decision aid that we're going to use to communicate that probability in a way that they can understand. And we're going to use that to justify the course of action that we would recommend. So if a very low risk patient has a probability of less than 2% and our normal course of action would be to recommend discharge, we still can recommend discharge. If they're high risk, we can still engage in shared decision making, and we can still recommend that they should come into the hospital. Okay, shared decision making doesn't mean that we wash our hands of all recommendations. We still can say, this is what we would recommend normally for patients like yourself who have this clinical context. The reasons why I recommend that are as follows. We've calculated that you're at high risk of having a heart attack. We know that we can, that when you've had a heart attack, there are risks to your health. If we don't treat it, it might happen again in the very near future, and it might be worse next time, and we leave your heart vulnerable to more injury and potentially to serious outcomes like death. However, we can reduce that risk by bringing you into the hospital and treating you and looking into this further. Therefore, we'd normally recommend that you come into the hospital. There are, however, alternatives. You could decide to go home. You could decide to go to home and have no treatment. We wouldn't recommend that because you would then be missing out on treatments that are going to reduce your risk of future heart problems, and that may mean that you have another serious problem in the future that we could have prevented. So we go through the options, and then we come to the decision talk, and that's where we allow the patient then to input their preferences and their values and tell them what matters to us most about this decision-making process. And we then integrate that with the information we shared with them, and we come to a joint decision based on all the information we've shared, their preferences and values. We check their understanding and we agree on it together. Let's go back to the study for a moment and talk about the primary objective. It's to establish the feasibility of a fully powered clinical trial to evaluate the effectiveness of shared decision-making guided by TMACS. This is how the trial works. We've completed recruitment to our control period where we didn't change the care of patients at all. Then we had a transition stage, which was much longer than we'd have liked because we were held up by a number of things. And now we're going into the intervention period where we're going to use shared decision making, and patients will be followed up by questionnaire at 30 days to look at decision regret, clinical outcomes, and a number of other things. There's an opt-out consent model here. So the evidence of consent is that you complete a decision aid together with the patient and you come to a joint decision. That's the evidence of consent. We ask you to give the patient a participant information sheet to show that they are fully informed, and there are contact details in there. They can opt out later if they wish to, with no penalty for their care. So it's quite easy, really. You just need to engage in shared decision making as part of routine clinical practice, give the patient information, and that's all we ask of you. And we'll do the rest of the follow-up. We're going to include any adult with suspected cardiac chest pain. So the full inclusion criteria are stated here. There's no obvious cardiac source for this pain or discomfort, and the treating clinician suspects that it might be caused by an acute coronary syndrome. We're going to exclude patients who present in a delayed way. So please don't enroll patients if their peak symptoms occurred more than 12 hours before they presented to the ED, because they've got a slightly different problem. They've not come in with acute chest pain. If they've still got some ongoing pain, that's fine. But the peak symptoms must have been within the last 12 hours. We're going to exclude patients with STEMI who require immediate PCI. We're going to exclude patients who need admission to hospital anyway for another condition, say a GI bleed or sepsis or an arrhythmia. And we'll exclude patients who have no mental capacity to provide written informed consent. Oh, well, actually, when we say written informed consent, they've got no mental capacity to engage in shared decision making. That's the evidence that we need, that they were able to engage in this process. If they aren't, then they're not eligible for the study. So I think that's quite simple. Now, Back to shared decision making. I've talked through the 3-talk model. Let's talk about the decision aid that we've produced. Now, we went to numerous patient groups to produce this patient decision aid, and we asked patients who were actually in the hospital, and so this was co-produced with them. And here's the little leaflet that we've got. Now, when you treat a patient, you've done your TMACS calculation, it comes to having a chat with them about whether they're going to stay in or go home. What we ask you to do is to go to the box file, which will contain one of these decision aids for every percentage probability that TMACS can produce. So it could be 1%, 2%, 3% probability. Pick out the appropriate one for that particular patient, and then go to the patient and take this to them. And we're going to use this decision aid to sort of frame our conversation with the patient. So we'll introduce the fact that chest pain is very common and could have been caused by a number of things. We were worried that it might have been a heart problem, and we've done some tests, and we can explain the tests that we've done. Moving on in this decision aid, in the next page, we can see the patient's personal risk. So here we've illustrated this for a high-risk patient, and yes, we do want to include high-risk patients. We asked patient groups, is there any specific group that we should exclude from shared decision making based on risk, for example? And they were very clear. You should include everyone, even if they're high risk. So this illustrates a high risk patient. So 95 out of 100 people like this patient are having a heart attack, essentially. And we communicate that with this diagram. We communicate that in words here and at the top. And then we've got the little infographic at the bottom, which says for every 100 people like you, 5 will not have a heart attack or have a heart complication within 30 days, and 95 people will. On the third page, we then talk about what heart problems a patient may have had. And in this section, there are 2 blank boxes there, which you can fill out based on your discussion with the patient. So is there anything the patient's worried about? We can put that in there. And then we can ask what's most important for them with their treatment. We then go through the options. Now, we recommend one of these options. So we can recommend option A in this case. And so we recommend that option, and the patient will stay in the hospital. But we also present the alternatives, going home and coming back for another test, and being discharged and coming home. But we don't recommend those. It's just allowing the patient to engage in that process. If they've got full capacity, they could, of course, choose to go home. But the point is they must be fully informed, and they must have capacity to make that decision, which has to be assessed by us. On the last page, we have our agreed option that we agree together. We fill that in, and then we talk about what's next. And we give this to the patient. We keep a copy of this decision aid ourselves as well, which we must keep in the patient's notes because it's part of the clinical record. So in Manchester Royal, where we have Epic, we can just take a picture of that, and it can be directly uploaded as a media file into the Epic electronic patient record. That's it. When you've done that, you've engaged in the shared decision making. You care for the patient as you ordinarily would, with the outcome having been determined by shared decision making, which is good practice. And we will do the rest. We'll follow the patient up. So here are the details for you to contact us about the study. If you've got any questions, please do get in touch. We welcome your feedback. There's also a survey going out to clinicians to ask how you felt about the process and the shared decision making, and we'd welcome the feedback from all of the clinicians that work on this trial. I'm also interested, if you've made it through this and you're not involved in recruitment to the TMACS Choice trial, in your thoughts about the trial and shared decision making in general. Thank you very much.